Respected Additional Director Maternal Health, Dr. Muradhidhar sir, our Administrative Officer Abhinav sir, Dr. Meena UNICEF, and all the dignitaries, all my colleagues, friends and postgraduates, and all the today we have gathered here to have a sensitization workshop for strengthening the midwifery collaborative care at the SCB Medical College. All these dignitaries we have gathered together with only aim to have a good outcome when a pregnant woman comes to our department. What are the outcomes? We can have a good, healthy mother. At the end of this, we should have a healthy mother, healthy child. The cesarean rate should come down. The birth asphyxia, so that all the more complications will come down. And as you know, maximum this morbidity and mortality happens during labor. So this midwifery training, they are the helping hands to our obstetricians, so that they will screen out the high risk patient and they can manage the low risk patient, and timely they will refer the difficult high risk cases, so that as an obstetrician we can manage the high risk cases properly. By that we can give a very good outcome to both mother and the baby. So for this we need the cooperation of our obstetrician faculties, and also the skill development and passion and commitment of the NPM trainees and their faculties, so that the end result will be good for everybody. And definitely the pregnant woman who comes to our department will have a happy birthing experience which will last lifetime, and she will definitely always remember with a smile on her face what treatment she has received from us.
क्या गोटे ओके
विशेषज्ञ माने कहबे जे व्हाट इज द रोल ऑफ मिडवाइफरी फॉर दिस प्रोजेक्ट तेणु एठी मो अप्रत्याशित भाव में अधिक किसी कहीकि आपण समय नष्ट करेंगे गोटे गोटे मीटिंग को जीवार अच्छी भुवनेश्वर तेणु खाली एतिकी मु कहबी जे जेकोसी काम जी भी करुँचा निष्ठार सहित करूँ खाली लोक देखाणिया भाव में सुपरफिशियली काम कले आपर भी बहुत प्रोग्राम रही जो थे कि हमार प्रोजेक्ट तेणु ये मो अप्रत्याशित भाव में अधिक किसी कहीकि आपण समय नष्ट करेंगे गोटे गोटे मीटिंग को जीवार अच्छी भुवनेश्वर तेणु खाली एतिकी मु कहबी जे जेकोसी काम जी भी करुँचा निष्ठार सहित करूँ सहित नियंतु सीरीयस हूँ कम सीरीयस हेले आप निश्चित भाव में क्वालिटी इम्प्रूव कर जेकोसी कम जी करोटा कि तो आप जानते जो अमेरिकार राष्ट्रपति जॉन एफ केनेडी फादर सी कहले जे तुम्हें जड़े घास कटाड़ी हेले भी जड़े भल घास कटाड़ी हो बेस्ट घास कटाड़ी वर्ल्ड तो से हिसाब से जेकोसी कम obstetrics gynecology is now a very vast subject. There is nothing more to tell about this. Starting from obstetrics gynecology, this is more concerned with the obstetric part, and if this is not managed properly, that may land up in many complications. Many complications. So one of the things I do not know much about this. As a neurosurgeon, I do not know much about this, but what I have observed in my practice, I have seen a lot many cases coming up after delivery complaining of low backache. Why should after delivery a patient should come to the neurosurgeon or orthopedic surgeon complaining of low backache? So that is not good. So what advice should be given after delivery? During delivery, someone might be using a spinal if cesarean is needed. If not needed, then there is some problem, because during delivery the abdominal muscles, rectus abdominis and all other abdominal muscles, they are very much weakened, protuberant like that. So the body weight which is transmitted through the spine, the midline weight bearing area is shifted anteriorly. If it is shifted anteriorly, there is a pressure in the spine. The spinal pressure is very well divided between different columns. There are 3 columns in the spine: anterior, middle and posterior column. So in pregnancy, during pregnancy, so this shift in weight bearing capacity is shifted more anteriorly. And after delivery, if the abdominal muscles they do not come back to their previous state, previous strength, then it is but natural that the spine is in the middle, posteriorly there are back muscles, anteriorly there are front muscles. If there is one of these, just like a tent, the tent गोटे बंधा हबो दौड़ी गुडा यदि ठीक भाव बंधा है तो टेंट टा सीधा ही रहबे गोटे पटू ढली जिवो. So anteriorly abdominal muscles are weak, so naturally it will pull back, and this imbalance in the power of muscles all around the spine, that will give rise to your backache. So this is my request. Don't have a very tubular vision. Let us have very broad vision. We want that after delivery, the mother should be healthy. The mother should be healthy as before, and she should be, she has many responsibilities for the family, responsibility for the society, the profession, like many things. So this is my request. So what we have taught to the midwifery? What is the midwifery people whom we are teaching, training? Do they give some advice regarding this? What is the post-delivery exercise normally they should do, and why there is a backache? Like this. So there are many questions. So you should be very broad to discuss everything and go in details and take history from each and every patient. What is the pre-morbid condition, pre-delivery morbid condition, post-delivery condition, like everything. So life is a wholesome thing. Don't focus into one thing only and forget the rest of the things. If somebody is having diabetes, hypertension, that's not my job. We send it to the cardiologist. he will take care of the hypertension. It's not like that. It's a part and parcel of the general care. So nothing more I can tell. All of you know this, and some other time you will discuss. And for till then, I wish that this workshop should be very fruitful, very effective for all those people who are involved in this. Thank you very much.
Now I request model sir to felicitation.
Sir, sir, look camera, sir, look camera. Thank you.
We are really thankful for having us.
Take care.
Said that we should have a healthy mother and a healthy child in future. That's the main aim. That in a labor comes out good, so that you have a healthy mother and a healthy child. You should remember that the mother is so important for our society. Who's the mother? When God thought that I should be everywhere. So couldn't be everywhere. So he made mother. He was in the mother. So mother, he said, I will be in the mother. And for us, a child is the most important part nowadays for our future. Is a treasure. So for this workshop, help you to maintain this. A mother and a good child. Okay, thank you.
Okay.
And other dignitaries and Dr. Padi, my friend. आदि समस्ते ये जो महत् कार्य पे समस्ते टे अच्छा know your work that's most important. जो काम पाए हमें जाके फिर हमें knowledge हवा दरकार. And love your job, your work, love your job, give 200%. जैसे तुम्हें करियर चाहूँ जो that is sort maternal mortality and in infant mortality still we are lagging behind. That we can improve our care and that is very important. I wish there is very success to all this workshop. Thank you everybody.
Madam. Camera.
Our National Director MH, Dr. Muralidhar Padi sir, to share the objectives of the Midwifery Initiative of the
Kirti Madam, Lucy Madam, Sir Bhai, and all the professor, assistant professor, PG students, senior residents, and house surgeons, and all the midwifery trainee and trainers, and Meena from the UNICEF. I am here to talk about the objectives of this midwifery initiatives of the state of Odisha. Our state is most likely third state to implement this thing, midwifery in year 2021. 21 already one batch of trainee already trained and posted in different MLCU like Kandamar, Kolangir, Capital Hospital, City Hospital and Malkanagiri. Almost 5 MLCU is now working and MLCU Malkanagiri will be working within a month or so. And so why we have gone to this thing? This is a new thing. Every gynecologist is So gynecologist is a broad specialty. They know almost many things like medicine, like surgery, pediatrics, and also anesthesia. So, this is a new thing for a gynecologist to learn how the physiologically we learn the delivery in a supine position, and this is a thing how we can deliver in a physiological position with change of position and with good outcome. So we should adopt this thing. And MLCU is not a separate from labor room. It's a part and parcel of the labor room, so that so we the midwifery and the obstetrician should combinedly work together to have a better outcome for mother and baby. We work from the first antenatal checkup to the postnatal checkup, managing all the complications throughout the thing. And it has been seen that with the involvement of the midwifery and the advanced care, all the parameters have increased, better in comparison to conventional things. So we should adopt this thing. And we should be, it is not that we are leaving after trials, we are leaving the delivery to the MLC unit and we will not take part of that thing. We should go with the thing and we should learn this new technique from them also. Then our referral will to the MLC will go on increasing, and even if our state adopt this thing later than few states like Gujarat and Andhra Pradesh, but our effort is good, and we are now best state to have this effect. And almost we have delivered maximum number of deliveries with MLCU till now. So our government of India appreciate in these things. Last meeting with Additional Commissioner Pawan Kumar around 1 month back. So they have taken our state as a model state. Third thing, it is a pilot project, and if we combinedly work together, this thing will improve. So I request my young brothers and sisters who are doing the PG and senior residency and also house surgeon, they should be broad-minded to adopt this thing. That should help our midwifery to have such practice. Because if you know something during medical college career, we can adopt in practice after our post-graduation. If we cannot know this thing, we will not be adopting this thing throughout our life. With this hope for cooperation from our PG students, I am living with much hope.
Encouraging words, I'd like to request our health specialist from UNICEF, Dr. Meena Som ma'am, please come forward and share the views of midwifery in chief.
Dignitaries of the dais, trainees, faculty from the OG department, midwife educators, trainee midwives, and everybody in this hall. It's a proud privilege. It's like almost exactly 2 years since we started this entire journey in this hall with the presence of Dr. Tushar sir. It's a pleasure to have you, sir, here. Sasmita madam was the nodal officer and she has been instrumental in taking this forward. And Dr. Kirti madam, Lucy madam, and of course Shama madam has been instrumental in taking and strengthening this journey. And I also thank Dr. Murli Padi for his effort and of his efforts to take this forward into the districts and strengthen the MLCUs in the districts. So that is also very, very supportive to take this journey forward. We started this journey, in fact, in this hall as a state training, midwifery training institute. To my young friends from the department, postgraduate students, I would like to say the operative word here, the key word is collaborative. It is nothing separate, nothing different. The entire intent of everybody in this hall and even in the hospital is to provide a positive, high quality birthing experience to the mother. So if we are to do that, what is that we need to do? It is to ensure a physiological method of birthing. We need to do what all we can do during the antenatal period, reduce interventions, reduce medical interventions. More and more we are seeing that the process of birthing is not being physiological but has become medicalized. So do we really need all the interventions which we are doing? So all these technical sessions will be taken in a while from now. So what is most important to understand that what entails high quality care, what entails a physiological birthing, what entails how do we give a positive experience, respectful care, birthing positions, the process of helping the mother to birth in different positions using gravity. We use lithotomy positions. In fact, I have also seen only lithotomy position during my MBBS career as well. So lithotomy position is not something which is very comfortable for the mother. In fact, we are operating against gravity. So it is a comfortable position for the service provider but not for the mother. So what else can we learn? What are the other things we can learn? This is not what we thought as old midwifery. It's not that. This is a professional midwifery training course on which all the scientific aspects of antenatal care, intranatal care, postnatal care, newborn complications, all of these are being taught to these young midwives. And it's a collaborative approach. The role of obstetricians and gynecologists comes in where there are high-risk conditions, where there are complications. All the low-risk mothers without any complications can be safely birthed by the professional midwife. And there has to be a constant communication and referral between the two sets. It's the mother may develop any kind of complications anytime during the process of labor or during pregnancy. Then that needs to be referred to the obstetrician. When the obstetrician fails, the mother can go safely into a normal vaginal birth path. Then she can be referred, the mother can be referred to a midwife. So this is what is the collaborative care. And here we are seeing a very positive example led by the Professor HOD, led by all the senior professionals here. So this has been, like Dr. Padi has already said, Government of India sees this as a positive model of collaborative care in the country because Telangana has been the leader, Telangana, Andhra Pradesh, Karnataka is also doing now, Gujarat has also been doing now. But Odisha has been the model here and giving this positive experience in the government setup. So now, like already has shared, 7 MLCUs in the district are already functioning. Students who have passed out from this SMTI already doing birthing in alternative positions using the skills they have learned here. So my submission, my request to everybody here is that let us do a collaborative work, let us join hands to see that the mothers get a positive birthing quality experience. Let us not do unnecessary interventions if not warranted. Where warranted, of course intervention needs to be done and you are the experts, you are the best persons to decide and take it forward. That's my only request. Let everybody join hands and do this together. Let's move on this journey. Thank you so much.
Session, I'd like to request Dr. Professor Sasmita Soin ma'am. Ma'am, the technical session we will start. Midwifery concept and importance of maternal care. Along with Dr. Sasmita ma'am, Madhusmita Paridoshi ma'am, tutor cum midwifery educator, SMTA. I request to start the session. Thank you.
This is an overview of basic facts on childbirth and basic human needs of women. Who is a midwife? What is the evidence for midwifery collaborative care? Why does India need midwives? And the impact of midwifery in public and private facilities. So coming to the birth experiences, it is a critical event in woman's life. Birth is a very critical event. It impacts our transition to motherhood. Self-esteem, if properly managed, it will increase our self-esteem or it may demoralize her. And it also affects our physical and mental health. And birth memories are lifelong lasting and imprinted into a woman's mind until her death. So if you give her a positive vibe, she will remember you lifelong. She will never forget you. And she may pass it to the next generation also. Because many times we happily say, she is my obstetrician, she has delivered me. If we have, it is associated with good findings, then they will have a good vibe. Otherwise, it will be negative impact. So what is the human rights in childbirth? So it should be respectful, we should be compassionate, and the treatment should be evidence-based care. Not that what you think you will do it. It has to be always evidence-based. And the patient has the right to know, have the informed choice. What she needs, we have to provide that along with the knowledge. And birth companion of choice. This is a must in each and every childbirth. Birth companion is very important. That will facilitate a normal vaginal delivery. That will ease our pain, and it will also have a positive mental effect. She can choose her birth companion, who may be her relation, or if privacy is maintained, her husband can also be the birth companion. That right she has. And she has the birthright to choose in which position she will deliver. Not necessarily every time she will deliver in lithotomy position. She may deliver in other birth positions which are comfortable to her. But we are facing the crisis during the childbirth. What crisis we are facing? Birth is institutionalized and incentivized. And there is over medicalization of childbirth, and there is increasing C-section rates, which may be curtailed by this midwifery collaboration. And most important, the disrespect and abuse that has to be looked into, because this is the one component. From my experience, I will tell you, we are having for Lakshya assessment, we are having patient satisfaction survey, and what we find, disrespect and abuse is one major cause. Patients are unsatisfied. And in midwifery, the respectful maternal care is the number one care we have to provide. So also as an obstetrician also, that should be our main motto, to give the respectful maternal care. That will definitely decrease the maternal mortality, morbidity and mental health condition. That has to be taken care by each and everybody present here. Specifically our postgraduates, we have to be very careful while you are dealing with the patient. You may be overworked, but patient is in a stressful condition when she enters into the labor room. Definitely she is under much stress. So we have to keep yourself in her position and deal with her very respectfully and feel yourself in her position. That is very, very important. My advice, you should this should be looked into. And for this healthy delivery, we need skilled birth attendants. The highest incidence of maternal and perinatal mortality occurs around the time of birth. So that's why the Lakshya program has come out, and for that also this midwifery has come out. The most important vital period in a pregnant woman is the time during delivery or time during birth. Maximum complications occur during that period. For that period, we have to develop skilled birth attendants. We have to create. So this is a graph showing the maximum stillbirth occurs during the intrapartum period. And maternal death also occurs mostly during birth. Similarly, 1 year neonatal death is maximum. The lack of skilled care is the main obstacle to better health of our mothers. So we have to develop the skill. Skill is the main thing nowadays. We have to develop our skill. Not only knowledge is not sufficient, we have to combine knowledge with skill. Knowledge-based skill is the very important. So the Lancet has given a remark that midwifery is a vital solution to the challenges of providing high quality. That the quality is important, not quantity. So now we have to concentrate on quality. So high quality maternal and newborn care for all women and newborn infants, not only in India because we have high population, but also in all countries. So every country needs midwifery to decrease their maternal and perinatal mortality and morbidity. So who is a professional midwife? Why do we need midwives? So according to the WHO FIGO, a person who having been regularly admitted to a midwifery educational program that is duly recognized in the country in which it is located, has successfully completed the prescribed course of study in midwifery and has acquired the requisite qualifications to be registered and are legally licensed to practice midwifery. So they are legally licensed to practice midwifery. So we should know what is their importance, what is its impact. This is the global evidence, the impact of midwifery. It has been shown that the midwifery-led models of care have significant impact on maternal and newborn health outcomes, especially on maternal and newborn survival. That is, we can avoid 83% of all maternal deaths, stillbirths and newborn deaths, Lancet. And if the standard is too good, then even 87% of needed essential care for women and newborns can be there. They can capture too. And this will increase 56 outcomes. So many outcomes are there, they can improve 56 outcomes. All pregnant women, especially with uncomplicated pregnancies, should be offered midwifery care. For this uncomplicated pregnancies to know, we have to know what are the complicated cases. So my request to all the NPM trainees, not only you will deliver only the low risk cases, but to screen out the low risk from high risk, you have to know both of these things, and you must know when to refer a case to your obstetrician. That is very vital. So by this midwifery, we have less need of syntocinon because their teaching is to go for physiological birthing experience. So induction is usually not advocated if everything is normal. So there is less need of syntocinon. Analgesic they give, usually they are taught to give mental, psychological and physical analgesics, not the drugs. And cesarean section rate is also, it has been seen less, decreased if you give this care. There is better maternal and neonatal outcomes. So midwife-led continuity care, profound impact on provision, experience and outcomes. Women who received models of midwife-led continuity of care, they are more likely to be attended at birth by a known midwife, because the midwife they are starting their treatment from the antenatal period. So usually while delivering they know the person who is conducting the delivery. There is 16% less likely to lose their baby and 19% less likely to lose their baby before 24 weeks. So chance of abortion is also less. Analgesics less, chance of episiotomy is also less. So they focus on normality of pregnancy and its potential for health. Protect, support and enhance normal physiology of labor, delivery and breastfeeding. So they go for spontaneous onset. Time is not a restriction if everything is normal. They allow eat and drink during labor. Mobility is assured. Non-medical pain relief. Freedom of choice of positioning, birthing. Delayed clamping, skin to skin contact. So they have the impact of recovery is quicker because patient is happy. There is less blood loss. Episiotomy is less, so chance of less blood loss. Only breastfeeding and success with lactation. When patient is relaxed, definitely lactation will establish faster. Positive transition to parenthood. Less likely to have mental health problems, which is a very burning issue nowadays. Most of the patients after delivery, they are going to depression. So mental health is also a very important aspect of pregnant women. If they have a happy birthing experience, definitely they will be happy. And less mental problem. Maternal and infant bonding is there, increased self-esteem, overall psychological well-being of the family. Not only the pregnant woman, but also the family is also happy. So this is the outcome of having a midwife-led labor care. So if they recognize any complication, they are supposed to refer it to the obstetrician. Obstetricians actively manage labor, and midwives, they are not taught not to intervene unless necessary. But that is the most important. You should know when to interfere. That is also very important. And your midwife educator, you have to train the trainees when to interfere, when they need obstetrician's care. That is very, very important. They develop a relationship of trust, and it is a collaborative model of care. So they are responsible and accountable for two lives. They have to be highly skilled, committed and passionate. You have to be committed. Though if you are in duty, patient has not delivered, don't leave her as such. You have to be committed. You take the responsibility that she delivers safely. So who can be a midwifery practitioner? So BSc nursing graduate or a general nursing midwifery diploma holder or staff nurse with 2 years of maternity care experience. They can apply for midwifery, and the course of training course is 18 months. We have completed one batch of training in our institute, and the second batch of 30 NPM trainees are there undergoing their training. So what is their work? They work in all stages of pregnancy. Antenatal care, they do the risk categorization. There is a risk stratification. According to that, they differentiate the high risk and low risk patient from the antenatal period itself. They advise regarding nutrition. We have a fast room in our OPD where they give the proper antenatal advice regarding nutrition, exercise and everything. So all our postgraduates, I request you all pregnant women, please refer the patient to the first room in the OPD so that they will get the proper advice. Because of shortage of time, we are not giving them the proper advice regarding nutrition, exercise, rest, everything. So we have the NPM trainees posted there. They can give the requisite training there. They also childbirth preparation. They empower women with the right knowledge, what to eat, when to sleep, how to travel, everything they tell. Intrapartum care and also postpartum care. So all the 4 components of a pregnant woman during the delivery period is taken care of by them. This is the statistics of Telangana, which is the leading state for the midwifery. They have started in 2017. We started in 2022. So respect, number 1 comes the respectful maternal care. If it is there, everything will definitely run smoothly. Even if some complication occurs, the patient will accept it happily if you have done the respectful maternal care. That has to be always kept in mind. They are doing this exercise. This is the butterfly exercise. They usually advise, which will strengthen the leg muscles, thigh muscles, and also increase the pelvic capacity, which will help in a vaginal delivery. So this is butterfly exercise they are showing. This is hip rocking. Hip rocking after 36 weeks, they are advocating hip rocking, which will also increase the leg, thigh muscles, abdominal, strengthen the abdominal and thigh muscles. So look at the smile on their faces. So this is the birth companion. They give him this is the husband can be a birth companion. So this is the impact of Telangana. Their cesarean section normal vaginal delivery rate has increased after this. This is a different position which will be dealt by my next speaker, and this is their experience they have told with a happy face. So the emergency LSCS and rate has drastically come down with this, and so also the 3rd degree, 4th degree episiotomy and all these complications. So this is the so she will tell this is the launch of NPM program in launching. So it was established on 2nd March 2022. Nodal officer of SMT is Professor Dr. Sasmita Swai Madam, and administrative authority for NPM program is the office of the medical superintendent SCBMCH Cutter. Unit head of the SMTI Principal College of Nursing SCBMCH. He was also program coordinator of this program. And first batch course was started from May 5th, 2022 to 4th November 2023. It was first batch is completed. From Capital Hospital, there was 6 number of students, NPM students completed the NPM course, and LMLSU functional there from 15th May 2024. DHS Malkanagiri, 5 number of NPM students completed the NPM course, and it will be functional from June 2024. And in Balangir, 6 number of NPM students was trained, and the MLSU functional there already it was functional from 16th
February 2024, and DHS Kandamar Kulbani also MLCU functional from functional from 4th March 2024. Total in the first batch 23 number of NPM students are trained here. And it was the second batch which was ongoing now. The course was started from February 1st, and from SCBMCH 6 number of NPMs are now continuing, and from DHS Cuttack City Hospital 6 number, then Jajpur, Jagatsinghpur, Keonjhar 6 number of NPM students are now taking the training, total 30 number. So this is our first sensitization program for first batch. And this, we are the MEs and first batch and second batch NPM.
They are very
students.
dedicated midwifery educators. That is
Madhusmita, myself Madhusmita and
Sanjukta, Mamta, Sucharita, Ritanjali, and Rasmita. So they are really very dedicated and very enthusiastic to train the MPs. It is the trainees, it depends on them how they extract from their educators and the labor room, our labor room and patients, how much they gain. They should be confident enough before passing out to conduct the delivery very safely, skillfully, and to have a good outcome. That will they will definitely contribute towards the maternal and perinatal mortality and morbidity and uplifting of our women. That is, they should be very passionate about their teaching, training.
so these are different activities in our childbirth education area, and these are different activities in our MLCU. And this is the data in midwifery OPD, number of delivery conducted and supported by NPM at MLCU, SCB, LR and SCBMCH Cuttack, City Hospital Cuttack, Capital Hospital Bhubaneswar from April 2022 till date, 24 it is.
Training center is only at SCB, Barampur is there.
And Burla is going to start.
So only Cuttack and Barampur.
So in midwifery OPD, it is functional from 22nd July 2022 and 1812 number of mother the NPM students have seen and childbirth education area, it is also functional from 22nd July and 1315 8 mothers have been seen by the NPMs, and labor room SCB Cuttack 682 mothers are supported, and midwifery led care unit Cuttack it is functional from December 2022 till now. It is 251 number of mother independently they have done, and the City Hospital 130 and Capital Hospital 132.
We have a ratio, total deliveries and deliveries conducted by
In labor room it is collaborative, supported by the and also independently some.
I think you should work out the percentage.
Total delivery.
Total low risk. If that improves, means
Data they are keeping very nicely, so we can take it out.
no, not their data and your data. So total number of deliveries.
And reduces unnecessary interventions, including cesarean sections. So this is a collaborative program between the midwives and the doctors, so that we will have a high quality, cost effective care. We will have maternal satisfaction, which is very important.
Increase maternal satisfaction, decrease
Cesarean section rates should be judiciously implemented. Unnecessary interference may increase the cesarean section rates. Say if midwifery is practiced, it can decrease the rate, because this is the very important concern of all the government and also the doctors, because of the increased C-section rates, we are getting lots of patients of placenta accreta syndrome, which is causing nightmares for us. So we have to decrease it. And there will be maternal bonding and lactation will be very successful. The collaborative model care, so task safety and team spirit, promote sustainable maternal and neonatal care, ensures equal attention and committed attendance for every mother to be. High-risk mothers are handled by obstetricians and midwives take charge of the low-risk cases, sharing accountability and competence. So final objective, both of us, the final objective is to reduce the maternal and neonatal morbidity and mortality, make the mothers happy and their long-term positive effect. So way forward, obstetricians accepting midwives as colleagues, so we have to accept them because without them we cannot also move forward. So they are a part of it. Midwifery is a part of us. So promotion of collaborative care has to be done. Evidence-based protocols has to be followed. Career pathways legislation build and enabling environment with obstetric champions. Thank you.
सर ठीक है ध्यान सर ठीक है मैडम ठीक है ଫଟୋଟା ଭଲ ନ ହେଲେ ଭଲ କେମିତି ହେବ
positions and how it is effective, that we will be learning in this topic. So mothers today, as we know, have an inbuilt fear of childbirth. Nowadays only 1 to 2 child they are having, 1 to 2 babies, not more than that. Even most of them are having one only. So but to have that one also, they are very fearful for delivery. So we have to remove that fear from them. So pregnancy is perceived as a medical condition nowadays where mothers need rest and reduced activity. Because I think previously at home, everybody you know, previously they are having 5-6 children and most of them are deliveries were conducted at house. So others, a young generation who sees them, they think that delivery is very easy, they will have it at home and not much of complication. They see their mother, they see their auntie and other thing, and most probably fear was not much at that time. But now, as every month you come, you have checkup, do this, do that, as we advise them. They think that it is a medical condition. It is some disease condition and they need rest, they need reduced activities. They should not do this work, they should not do that. We always keep on telling them, don't eat this, don't eat that. But we have to tell them that this is a physiological condition. This is nothing pathological. So they have to behave normally, and as before they were doing, they have to continue the same thing to do. Then in 2018, WHO shared a clear recommendation for intrapartum care for a positive birth experience by encouraging the adoption of mobility and an upright position during labor with low risk mother. So you can see here a historical picture how childbirth was continuous previously. So this is women have been active during birth for centuries and adopted squatting, kneeling and sitting position. These positions were adopted previously, long back. But now we have forgotten all those positions. Then in 18th century, see how the delivery was conducted. It was assisted by 4 nurses and the delivery, of course this is not a proper position, it's a lithotomy position and this is not very comfortable position. But in 19th and 20th century, the fashionable for 18th century, fashionable for many women in European countries to labor horizontally coincide towards medicalization in childbirth, facilitating performance of obstetrics maneuver and procedures. So Marie Antoinette was the first woman to give birth intentionally on her back for the view of public. King Louis XV did not like the obstructed view caused by the birthing stool, which was historically used instead, insisted to view the birth with her in stirrups. French doctor Francis Marisu believed that next. So this is the position nowadays in 19th and 20th century. This is the position we are commonly adopting, that is lithotomy position. Patient is asked to lie down in the bed. So, but this position is
actually not very important. And why it is not very important? Because lack of respect for women is there if we don't adopt the preferred position. So some women prefer squatting and kneeling position, and resent being made to birth in undesirable position causes humility. And adopting an undesirable position made women passive participants in birth. Restricting to lying position a barrier to facility care. So why do we restrict ambulation? Gravity is our greatest aid in giving birth, but but for historical and cultural reason, we make women give birth on their back. So when you want the ketchup to come out of the bottle, you don't lay the bottle down. Okay, you have to pour the bottle. So by gravity it will come down. In the same way, when you want the baby to come out of the mother, same position you have to adopt. So the fear actually the fear should go away from the mother, and the fear is mostly due to cultural belief, the medicalization, the myths, and the birth environments, and the cultural beliefs. So there are cultural beliefs after delivery, you don't take this food, you go to one room. Those are so many beliefs were there. For that, there was fear of giving birth to a child. So choice of labor and birth position encourages a woman's sense of control and reduces need of analgesia. So listen to women, what she wants, and respect her desire. Respect and support birthing positions of individual's choice. And maternity care is one that women want, and it should be women-centered. So empowering women and giving her support, and it should be evidence-based, treated by equality, equitable, and offers and supports informed choices. So we have to ask the mother what she wants. She should be counseled, and she should be given prior advice what to do. When pain comes, what to do, and what should be her position, in which position, whatever position she is comfortable, she should be given. Then involvement in decision making, support in labor, a positive relationship with the care provider, not being restricted in choice of movement and position, have been found to have a more positive impact on the labor process and maternal experience. So, there are different birth positions, like little data, there is little data, different positions are they're adopted. But I think after this MLCU is widespread in our state, lot of data will come out. Because this practice is not very popularized now, and not much of data is there. So little data to show significant effect on position is not there. Then choice of labor and birth position encourages a woman's sense of control. Mobility during the first stage of labor decreases C-section and forceps and vacuum extraction rate. So, women should be encouraged to move and adopt whatever position they find most comfortable, and that is also nice guideline has told that mobilization reduces complication caused by restricted movements and semi-recumbent position. So, mobility increases power, passage, passenger, and the fourth one is psyche. So, power is gravity helps to bring the child down, and passage is effective working of the uterus for optimal fetal positioning, and the passenger, that is the baby, has less chance of compression. There is compression, less compression to maternal aorta. In lithotomy position, the aorta is compressed. So when there is less compression, baby gets more oxygen. So birth asphyxia is reduced, and increased maternal satisfaction and better birth experience. So evidence advantage of upright birth movements is that it causes relatively shorter labor, effective working of the uterus, increased pelvic diameter, reduced need for medical intervention, and better birth experience and satisfaction. So this shorten your hour of birth, that less time is taken, then reduce need of an epidural analgesia by 20%, and reduce the risk of cesarean section by 30%. So let gravity help the baby to come down, come out, and this is the easiest exit possible. So position that take pressure of the sacrum and facilitate opening up of the pelvis, initiate spontaneous birth and reduce the need for an instrumental delivery. Upright position and walking in labor are associated with reduction in length of the first stage of labor, the use of epidural anesthesia, and non-supine position is ideal for the birth. Due to there is chance of fewer perineal injuries, less vulvar edema and less blood loss, shorter second stages, require less pain relief medications and fewer perineal injuries. So there is a comparison and it is seen that between upright and non-upright position. So it is seen that the upright position is more favorable and there is less unfavorable fetal heart pattern. That is in upright position, and in lithotomy position there is more fetal asphyxia. So deep squatting position found no difference in use of episiotomy. However, there was a greater occurrence of perineal tear and instrumental delivery when the patient is delivered in lithotomy position. So the best position for avoiding perineal tear is lateral position. Woman lying on her side with the top leg supported by an attendant, it avoids 66.6% perineal tear, and squatting percent avoids 42% perineal tear. So the benefits are findings suggest several possible benefits for upright position with the possibility of increased risk of blood loss greater than the loss is less than 500 ml until such time as benefits and risk of various positions are known with more certainty and more data will come. Women should be allowed to make informed choice and give the position of her choice. So after making lot of deliveries in different positions, we can come out with a conclusion that which position is best for her, and with less blood loss and with less discomfort she is delivering. Thank you. Now we will.
So standing, leaning forward on the partner, birthing bowl, walking, sitting upright and swing, lunges in leaning and or standing, sitting on chair, leaning on backward on chair. So there are so many positions we will demonstrate. We will see the video simultaneously. We will do it. So standing and leaning. So ask it. It takes the advantage of gravity. Contraction becomes less painful and more productive. Lines baby with an angle of pelvis and helps to descend. May speed up labor if you have been lying down. May increase the urge to push.
You can use this theory by sitting in the reverse way to widen the pelvis. Or if you will tired, required. If required, the partner or the birth companion or the professional midwives or whoever the healthcare providers there, they can help in that message or giving the heart compression if required by the mother. Right after. Lunges, if available, then it will enlarge the pelvic outlet
nearly 20% to 30%. Then another with this position, we are doing none. Just support with the mother. She is the midwife and she is the pregnant woman. Fine? What? Side by side. এটা করিয়া দ্বারা
कौन हुए आम विभिन्न वे रे आम कौन करूँ आमर वाइड करूँ आमर पेल्विस आउटलेट को so using birthing board available न होला तो हमें सिंपल पिलोज भी हमें यूज करना देख तो पड़ी तुम्हें बस 75 तक दे एटा बड़डा सब सो ये बसियार भी गोटे नै उठी जा 5 सेंटीमीटर उठिया पड़ी जा मु करछि मु बस
सर डिफरेंट साइज
सो ये गोटे परफेक्ट साइज अछि परफेक्ट साइज अछि हमें पड़ीबानी साइज हिसाब रे तो हमु जेतले पेन होबो हम खाली समय रे हमें वी कैन रॉक बाय एमिति भी रॉक करि परिबा वी कैन रॉक side by side and also we can move our pelvis by anti-clockwise and clockwise and if we will have the pen then we can bounce on ball so during contraction and hame jitale bhi feedback magichu after bouncing or each position we need the feedback from the mother so ko position ta मा को भल लागुची से निजे कहबे सो एमती बाउंस करला परे हम बहुत सुनिछु जे मामू बहुत भल लागुची दे मे फील लेस पेन और इन दिस सेपरेट पोजीशन वी कैन यूज आल्सो बैक मसाज एंड आल्सो द हॉट और कोल्ड कंप्रेशन और if you are tired you can use the supporting the partner and the partner will massage the back if required or you can put the ball on the side of the bed and also do the hip rocking
यार चारिटा साइज अछि 55 65 75 बड़ साइज
and it should not be outside the toe line
से टो पर्यंत बेड
then again
वाला साइड कटिंग
I will take a white for then again another side next leaning lunge by मैडम से तासे केते थोर चार थोर पांच थोर तारा इच्छा सब कर परियो so comfort हिसाब रे so in mobility resource shows that we will reduce 1 hour 22 minutes mothers like this position and this position it helps us to rotate the OP position to OA position
ओपी पेशेंट सब कंफर्टेबल
नहीं मैडम ओपी पोजीशन रे कंफर्टेबल हां मैडम पठन ए पोजीशन मैडम सुन आपण
ब्रिटिश सब्सिडी बय उड डोडला
नहीं मैडम आपण पठन दो
बुइस
सामना पटे बॉल सामना पटे सपोर्ट करो
ए आगो दिस
सेकंड स्टेज रे खाली बसे देले भी न बेटर
हां सर स्टॉल रिपोज रे रिपोज बॉक्स पूरा कवर हबो इट टाइट हबो गोटे पटे रॉक करिवे हां सर गोटे पटे एंट्री करी आ गोटे पटे
जो चर्नी से जो दही बड़ा हले दे
ठीक है मैडम की पोजीशन है
दही से छुआटा को मत कोन करछु गसमडा का खाइबो
हेलो हेलो हेलो
बढ़िया वाली बात बस छुआ समझ नहीं पाए
Angry cat and camel. So এটা আমার antenatal period রে কলা পরে কোন সে গুড habituated হয়ে যায় আর মদর যেতবে লেবার রে থাকে সে এই পজিশন আলফা পজিশনটা ইউজুয়ালি করে ইচ্ছা করে আউটলেটটা গোড়রে দিয়েছে Okay. हाँ पुरुना सब पुरुना पाठ नुआ नहीं नहीं पुरुना मोहल्ला वाली मैडम आमे जेमती चूड़ी गोटे पिंधिया पे आमे जेमती सेपरेट एफर्ट करू लाइक दिस था जदि किछि नै जेतबेले बर्थिंग स्टेज इज मदर साइलेंट पोजीशन रे डिलीवरी हबा चाहू बर्थिंग स्टेज रे ही इज क्लोज एट legs wide open जदि हम पाखरे किछि नाही भी peanut gym ball we can use the pillows instead of peanut then supported squat
सेटा एमएलसी भितरे आ अछि
supported
ये नथिले भी एटा सपोर्टेड स्क्वाट
जो पेंडुलस एब्डोमेन होची
फिटल एक्सिस्टा पेल्विस हेले एंगेजमेंट नहीं से माने एडवांस आगे जाई पान नथि वर्तमान से पुस्तक मान
आवर्षण होबनी मैडम आवर्षण होबनी
लेखि होछि जेटा लेवल केते वीक से एटा करबो
Okay, now.
So I am the midwife and she is the with the half of professional midwife or partner जदि रोग जो मो पाखरे अछि सी सेटा को हेल्प से करि परियो एटा कोन कहउछो रिपोज कपड़ा थैंक
Michael Gujarat.
Birthing position. We are going to another step, that is non-intervention. This interventions in labor. As you all know, labor is pregnancy is a physiological condition. You can't tell she is a pregnant patient. She is a pregnant lady. Hence, pregnancy is not abnormal. Pregnancy ends in when it is low risk pregnancy. Most likely, it will land up with normal labor. So, main aim of all the obstetricians, everyone is to maintain the normalcy of labor and limit the intervention. Of course, when there is any abnormality, we have to intervene at that time. That is not denied. That will prevent so many maternal and perinatal deaths. But unnecessary intervention is also harmful. With me, Mrs. Mamata Jena will be there. I will be presenting one part and she will be presenting the next, most often as usual, the applied part.
Again.
Hopefully now we are more educated, we are more well equipped with knowledge. So it results in over medicalization of childbirth and associated harm from these interventions. Also, it doesn't come with free. It is also there is a cost, and there are so many long-term complications. Major interventions, what we do is we go for induction of labor. Definitely, induction of labor is there is a role in so many complicated pregnancies to reduce the maternal as well as fetal complications. Also, there is rising cesarean section rate, but all these are not justified by proper intervention. Rather, by reducing the intervention when it is not needed, we can reduce these rates. All routine practices have to be revisited because small things. When we were postgraduates, only patient lateral labor sent to antenatal ward. But now it has become a practice. Any patient comes with pain abdomen, paras lady or cervix one finger, she will be kept in labor. Because these chains of habit of keeping the patient, avoiding any problem, they itself are very weak, but they are felt until they are too strong to be broken. Our labor room is flooded with the patients. So many patients are there to be, they do not have the merit to be kept in the labor room. But they are, by practice they are kept there, so it is overcrowded and there are so many complications. So, just come, avoidable intervention. Just one example. Suppose a lady in labor complains of weakness. She is complaining of weakness. Weakness may be something or other. We may give some fluid. There is no contraindication for that. But we think no. Let us give some IV fluid. What we do? We put Venflon. In one prick, it didn't go. So, second poke to give IV access. We get one DNS 500 ml, start drip with IV set. Then, after that, as usual, she complained of shivering. Oh, shivering! The sister called you, he gave one injection of Avil. Then, during this, giving this injection, somehow she didn't cooperate and there is extravasation, hand gets swollen, pain and thrombophlebitis. This is the cost she has to pay for complaining of weakness and our intervention of giving an IV fluid, which we should not give. Let us see what we have to pay. 2 Venflon plaster, alcohol swab, DNS, IV set, Avil, Thrombopho, because there is thrombophlebitis, and this costs you 1,000. Patient is not paying. Even we are not paying, as we think. But practically, our government is paying. Ultimately, it goes from our tax money. So it is not just a simple thing from what I am telling. It is all evidence-based. Approaches to limit intervention during labor and birth is opined by our authorities at the SCOG. Suppose you discuss a clinical scenario. A pregnant 26 weeks, low risk, BMI 24, good weight 62 kg, 39.2 weeks, with emergency department with pain. On examination, vitals were all stable. Uterus 39 centimeter, 2 contractions in 10 minutes, is 30 seconds, cephalic presentation 3.5 palpable, and partial effaced 1 centimeter dilated, -1 membranes present, pelvis are present. If any postgraduate is present, what will do with this patient? You are in triage. What will do?
Madam, mic.
Process option is join the motion. What will do? This is the patient. Patient comes with pain.
Madam, patient will be advised for ambulation with hydration.
Where?
Patient can be transferred to antenatal ward.
Yes, in our setup we are admitting to antenatal wards because you can't send them back. Patients come from a very long period. But if the nearby patient, we need not admit them. So what is the ideal time to admit?
Madam,
admit to labor room, I mean.
Madam, when there is actual labor pain onset.
Actual means
Madam, true labor pain when there
is true labor pain, but she is in latent labor.
Active stage, madam.
Only you will admit the patient to active labor. Will there be benefit from early admission? To come nice more relation अच्छी से कहीं बाहर रहिबो तब without any complications or this.
Triage को असली कौन?
Triage को असली antenatal work को पठिबा हैला. There is no controversy about it.
नॉले तापर को 8 घंटा रहिलानी टिके सिम्पटम पके दो.
Will there be benefit from early admission? किसी benefit अच्छी?
No.
Will there be harm from early admission? ना, सीमा से पूछी मैं.
नहीं, तो तोड़ को MLC को पठे दो.
lateral labor madam ଆମେ MLC
MLC वाला
ସେମାନେ ବି lateral labor ରଖିବେ madam there will be the mother only admitted into MLC, that is whenever the mother is in 5 to 6 centimeter of dilation, then after that she will enter into the MLC. Mane admit karibeni boli da ame admit kardeba same no, we will send them to antenatal ward. There should not be a controversy, no mismanagement henceforth. Will there be harm from early admission? Both harm achi.
Yes madam.
Starting from vertical to everything. Are there any studies? Yes. Early versus late admission. This is evidence based. So it's how much, how far, how late. There is a study taking 1200 women before and after 4 centimeter dilatation. CS rate was reduced from 18 to 4%. There is gross reduction. Only by one thing, admitting low risk patients, not in latent labor, only in active labor. Only this thing. Madam?
Just one question you have to ask the pregnant woman when you are sending her to the latent. How often do you feel the fetal movements? If the fetus is moving or not?
Madam, low risk, madam, say question पे आसिबा. Intermittent auscultation. When I will highlight that. Oxytocin is increased. Support in latent labor, non-pharmacological pain relief option, facility where they can stay and not get admitted. आमर एठी जो माने दूर पेशेंट आछंती से माने तो एडमिट कर दोछु एंटीनेंटल वार्ड को पठौछु जोठी पूरा पाखरे तांकर एंती सब अछि बहु जगह रे से माने से रखी पारंती जोटा मी रुति मैडम ख्याल लाग बोली किछ कहे बोली रखी पारछंती से माने से रखी पारिबे where they can stay. Support in labor. Is it important? आमे पेशेंट को गळे दोचे पाटी बनाते बेला तो बेसी पेन होनी तो था. Is it normal? It should be done? No. They should not be unsupported throughout labor. They should get support. This support in labor, it is effective in reducing interventions. It shortens the labor. Increase spontaneous birth. Less operative vaginal birth. Decrease cesarean. And another thing, all these things we understand. But another thing from statistics, it is already seen that all fetal distress incidence is much reduced when we are giving birth companions. Birth companions, but तांका निजे भी doulas means decrease low observability. So fetal distress incidence is also decreased by giving birth companions. And less need for pain relief. So you know, whenever you are getting anything, if somebody is there to talk to you, whom you like, you will get less pain, even if it is headache or anything. Similarly, when she is getting labor pain, somebody near and dear is there, near her, definitely pain will be reduced. So, what is suggested, never be left alone, familiar partner should be with her. If not, then doulas, as madam told, they are appointed birth companions. They are appointed by other authorities. They are not their family members, but they will give the same care. They are trained. Rather, they will give it in a professional way. Needs planning, privacy, and policy. So everything should be planned. And the lady, she is not a patient. The lady, laboring lady, is a party to it, and they should discuss it properly in privacy. There should not be, suppose somebody she fears, like her mother-in-law is standing there and you tell that we will be discussing, she may not like it. So according to her message, you have to do it. If you are a obey labor, what would you prefer in the back? To be the back companion? When it was asked to 115 women, I don't know where this study is done, but 88, maybe Telangana. I'm Odisha रे कोई भी नहीं किया. कोई भी हमें implement कोई भी नहीं सोचे. Because MLC रे पूरा चंदी very good, very nice start. So they prefer their partner her husband to be the bath companion. What is suggested? 2,79,000 Medicaid, Doula care versus non. They have seen that cesarean section is reduced, preterm birth is reduced, and this reduction in cesarean section odds ratio is 0.59, almost halved. That is very important. So investing in doula care for reduction in cesarean section rate is considerable, because the money we are spending for appointing these doulas will be much less than the cost of the cesarean section, excluding the morbidities and mortality. Only the cost and
No cost when
if those persons are not there, you can go for that. See, complaints of increased pain on examination, the same patient. She is effaced, 4 cm dilated. What should be the definition of active phase? आमर की पोस्टग्रेजुएट अच्छा है बोले मैं सब पढ़ेगा नहीं ते गोटे अच्छा आओ समझ ते गोटे पिला अछि
से अछि एटा जीव केतरा माने झाड़ू मारी गले समस्त से
बसमुटा के तो 4 cm 5 cm or 6 cm till now we are admitting the patients at active labor as 4 cm. What you are doing madam? From 5 to 6 cm we are admitting 5 to 6 cm hela so 4 cm admit kornati, but in our labor room our is obstetrician led care unit and in front of that there is midwifery led care unit. So we are admitting at 4 cm, they are admitting at 5 to 6 cm. Okay, fine.
काली पेशेंट आगे हमके कहलो ताको
गोटे सेंटीमीटर पर
antenatal ward and longitudinal lateral phase active
so why centimeter as active? So again it is evidence based comparison of pregnancy outcome between 4 and 6 cm cervical house dilatation to demarcate active stage of labor is a study, and they have seen that using 6 cm at the start of active phase reduces CS rate by 11%. It is as high as 11%. And it is seen that if you admit at active latent labor, you are also increasing the rate. The labor care guide. Vandana is not here, I think. It was taught, it was presented in this seminar room regarding labor care guide. Here there is the WHO patograph. This is the labor care guide, means there is non-intervention policy. There is no alert line. There is no concept of alert line. When whichever time it takes, but there is no complication, means we can allow labor. But I don't think we have implemented it now. Now see, complaints of increased pain on examination is effaced, 4 cm dilated. What you will do? What is the ideal tool? Two tools have associated harm. CTG versus handheld Doppler, whether midwives are needed or not. What you will prefer? CTG or handheld or stethoscope? Because now artificial intelligence has come. Let us be intelligent, at least natural intelligence. So now the concept of intelligent, structured, intermittent auscultation concept has come. It is established also. So in low risk mothers, there is no need of admission test. There is no need of admission test by CTG. We have to go for this intermittent intelligent auscultation. At the time of admission, we will auscultate for minimum 1 minute in each session for at least 10 minutes. During that period, we will see what is the contractions and what is the baseline heart rate. In between contraction, what is the heart rate? If it is 110 to 160 and there is acceleration or there is no deceleration, and for deceleration, decrease in heart rate, you should see after the contraction passes out. For last 10 to 15 minutes, just like admission test, in low risk patients, you see by your stethoscope or Doppler. If it is normal, then during first stage of labor, in low risk cases, you auscultate at an interval of 15 to 30 minutes. And in first stage of labor, and every 5 minutes or after each contraction passes up in second stage of labor. During this ongoing auscultation, during first auscultation, just like an admission test, you will see the baseline heart rate, increase in heart rate, and then no decrease, and these things. Mainly these three things. Then ongoing, we will see after interval of 30 minutes or 15 minutes, 15 to 30 minutes, only see the fetal heart auscultate after the contraction passes off. That is important.
It's connected to transducer, na? It do data आसुची केते गोटे ट्रांसड्यूसर रे रखी करी बेड रे सेटा कनेक्ट होची बोले मॉनिटर
नहीं सेटा से ड्रग ना सेटा पड़िबो ना एटा जस्ट अल्ट्रासाउंड चार्ज करके तब जस्ट खाली ते दे देले जागियो हाते एडी डॉपलर देखला एक्चुअली बैटरी भी तो अछि एक्चुअली ना आंखो अच्छी अरे मानो एटा फुल बने का देखि चार्ज तो एडी जोटा ट्रांसड्यूसर रे लगि तो ट्रांसफॉर्म अछि सेटा सीटीजी सीटीजी नो सीटीजी मुचेन नै मोयो तो 30,000 टका दाम सीटीजी नो एटा ट्रांसड्यूसर कंटीन्यूअसली फिटल अल्ट्रासाउंड देखो तो गोटे खाली मॉनिटर रे रेट टा खाली देखो तो एनीवे if there is any abnormality, if the fetal heart drops just after the contraction passes out, or in first stage you get any abnormality, just I am advising all my educators and NPN trainees, just call the SR, senior resident on duty, so that they will see and decision is made whether any corrective action is done. You have to go for corrective action. If it doesn't correct, then it has to be intervention should be done. So intervention should be done after proper assessment, not directly and in every case routinely. So another thing, complaints of increased pain on examination. Are there any harmful effect of repeated vaginal examination? It need not be exaggerated. Whatever you tell, that is correct. Cost of vaginal examination, we do not know, but because we are letting it free, but in every private setup, it is there. Any recommendation? We are doing it 4 hourly. If there is no acute emergency. No evidence as to which method is better. Routine or indicated. Routine means every 4 hourly. Or indicated means when the contraction increases or in the gush of fluid or blood or cord. Optimal frequency is also not clear. Increased examination is linked to infections. Only thing established is if you do repeated examination, intern will do, then first year PG do, then senior PG do, then labor room, then the unit round comes and they will do. Definitely, the chances of infection is increased. Lowering the number of vaginal examinations will lower the infection rate. It cannot be exaggerated.
It was found during COVID because this examination was reduced.
Infection rate is reduced.
Death reduced. Sepsis death reduced. Which means how many women we kill? Just see the opposite side.
Then see complaint of increased pain on examination. Only that is 4 cm dilated. Should we do an ARM, artificial rupture of membrane? Are there any advantages? Are there any harmful effect? Any recommendation? And of course, in all private setup, cost of ARM is also important. But if we think so many things, if you do ARM, she will deliver within 1 hour, half an hour, not that. What the evidence tells, according to Cochrane database, mean difference is only 20 minutes. However, oxytocin, need for oxytocin augmentation is less if you do ARM. Advantages: does it decrease duration of labor? We have seen the Cochrane values. Does it show the color of amniotic fluid? Yes, it shows. But if everything is normal and fetal heart rate is normal, we should not expect that color of liquor will be meconium staining. In unusual cases only that can happen. Intentional ARM. They have seen one study, primary amniotic to step up the contractions and it acts by prostaglandins, liberating prostaglandin, that excellent modes. Disadvantages, it cannot be exaggerated. It causes decrease in amniotic fluid, increases variable deceleration, infection rate becomes higher, cesarean section rate becomes higher. You can see here the relative risk is 1.66. Dedagun to adhika padhigala. Only by doing ARM. Because once you do ARM means you are committed for the labor within few hours. High HIV prevalence areas or any infection, HB, HCV or anything. It should be done. No doubt in cases of eclampsia where we have delivered within 12 hours, we have to go for that. Even if it is 20 minutes, 30 minutes, it is beneficial. But when it is indicated, we should not always. Another thing, would you like to place Venflon, venous accessing routinely in all cases in low risk labor? Only when indicated. This is the scene, very frequently seen in our postnatal wards. After cesarean section 2-3 Venflons, they will carry it for 3-4 days. All the sisters should not make her fasting, because if you keep her fasting, then what will happen? There will be dehydration, uterine contraction will be hampered, everything will more exaggerated and chances of cesarean, all the complications will be more. So, give her some pain, hypoglycemia should be prevented. Women need good nutrition in labor, you all know. So, this is the slide we showed. Nutrition in labor is often overlooked. You can see when she is in labor for 20 hours, in 100% of cases there will be starvation, fistuliosis, dehydration, acidosis, literally there. So, now she is 5 cm after so many hours. Will you give oxytocin? If she enters in our labor room, I am sure in 100% cases oxytocin will be given. But as you always assess the contractions, if uterine contractions are good, if she is progressing normally, what is the fun of giving oxytocin? Application of recommendations should be based on consideration of the general condition of the woman and her baby, her wishes and preferences. You cannot give her oxytocin without her choice, without her information also, without informing her. Augmentation of labor should be performed only when there is clear medical indication.
Workshop, and I thank profusely from the bottom of my heart Meena and Murali sir and their team from either side, from UNICEF as well as from the SMGI, for giving us this opportunity. So, as I start, we've been given newborn outcomes in midwifery practice. I'll be failing my duty if I don't mention an amazing person, Arun Singh from Jodhpur. I was amazed, and after all these years, after having been an obstetrician, after having headed the department as superintendent, I had to learn so many new things there. So that's what I hope that the postgraduates would have been there, but they are hopeless, there's no hope for them. So we have been given the session, Sucharita and myself, newborn practices, newborn outcomes in midwifery practice. I'll be giving you the research side of it, which Arun Singh had given us, and she will be giving you the actual practice of it. So we have 3 perspectives. Hello, may I have your attention? No talking, please, Lucy madam. Lucy madam, your attention, please. I want your attention. There are 3 perspectives in this session. One is optimizing perinatal transition, which I think it started right from the beginning of this sensitization workshop.
then revisiting cord clamping practices, and then neonatal resuscitation practices. And special gratitude and acknowledgement to Professor Arun Singh, an amazing personality with amazing perception of his subject. I have neonatologist par excellence from Jodhpur. So, what is perinatal transition? Perinatal period we know is from 28 weeks to 1 week after birth, and there is a physical aspect to it, there is an emotional aspect to it, and there is a spiritual aspect to it. So physical starts when the effective invasion of cytotrophoblasts occurs into the media of the spiral arterioles, leading to a high capacity, low resistance system. I wish the postgraduates were here. A high capacity, NPMs also, it's very important for you. This high capacity, low resistance system has to be there. But when things go wrong, it becomes just the opposite. It becomes a low capacity, high resistance system. So in both these systems, how we deal with the newborn to be born. Okay, and as a result we have in fetal life, the lungs are not involved, we know, it's involved only in 10% of the blood flow, and the placenta is the organ of respiration, and more than 50% of the fetal cardiac output and is circulating through it at any one time. And it must, at birth, it must rapidly change from 10%, the lung capacity lung involvement has to change from 10% to 45 to 55%. This is the theory part of it. Okay, so what happens during birth when the baby is born to the atmosphere, and what happens? Those intricate processes, we know this is the major part of it that happens. Okay, factors affecting perinatal transition is therefore genetic and epigenetic, immunological, inflammatory, nutritional, route of birth, peripartum oxytocin, and cord clamping. All these factors are involved in the perinatal transition. Okay, now we know of, Arun Singh mentioned there are two. One, Hitler caused the Dutch famine, and Churchill caused the famine that we had in India. So, we didn't study our women, but it happened that 3 generations were affected because of this lack of nutrition. So, nutrition is extremely important, and well-nourished woman in labor, how it affects the childbirth, and we know that it continues into 3 generations. One malnourished mother will deliver malnourished baby, that malnourished baby will deliver another malnourished baby, so 3 generations it continues. Now pediatricians talk of the 1000 days of early life. Unknown to the mother, her food choices during pregnancy and even during breastfeeding would influence the infant's palate. So right from pregnancy, whatever the mother is taking, always Arun Singh would add the emotional side of it, the psychological side of it, the spiritual side of it. Okay, and again, I gave a thesis to one of my postgraduates. Co-guide was Professor Hemamani Rathav, the public health dentistry. That was Swayam Siddha, who did a thesis on preterm labor and oral hygiene. So you have to take care of the oral hygiene so that this perinatal transition, even a child can be born with caries. So you have to be extremely important when you are dealing with antenatal women throughout. You have to take care of their oral hygiene also. Ask them to brush their teeth at night and check up their teeth. There shouldn't be any caries. And regarding sweets, they should immediately brush their teeth or wash immediately after taking sweets. So these are the things that you have to pay attention. Then we come to maternal stress. Mental stress also doubles the risk of behavioral problems in boys and girls at 4 to 7 years of age. So mental stress should not be given to during perinatal transition. Then gene environment. There is epigenetics and gene environment changes. I have been to Lonavala where the APA, Association of Prenatal and Perinatal Psychology and Health, they have one in coming January also. How epigenetic changes, epigenetics, genetic configuration changes by simply a mental attitude, by simply taking abnormal food, by simply so many other things. Okay. So, and autism, influence of autism also. Then regarding cesarean births, if the baby born from a cesarean by cesarean section has more chances of developing autism. Odds ratio is 1.23. So that's another case for not going in for cesarean section. And women during antenatal period, you must make them aware that if you have cesarean section, you will have more autistic babies. Would you want it? Then she will demand that obstetrician who is wanting to do a cesarean section, she will say, I want a vaginal delivery. This is the aspect of it, one must be absolutely got. Then a vaginal birth, if you have microbiomes, vaginal vagal signals are there, and you have vaginal birth microbiomes are healthy, whereas cesarean birth microbiomes are related to inflammation, immune regulation, and xenometabolites and other hormones which are affected. Okay. Then the white.
साउंड टा दे
साउंड अच्छी मैडम
लेकिन ममता मैडम एटा कहि थाते मन फार्म कर दे
मो लैपटॉप पे बहुत लाइट है एबे से पड़ गया मोबाइल तो लाइन पड़े लाइन पड़े
ऐसे एलसीडी रे पूरा अच्छी साउंड सिस्टम टा फैजान पड़ गला ओ एनीवे बिना साउंड रे देखो
देखा चित्र देखा
The physical hand message of waking body parts to tense the muscles and increase blood flow. So this is the physical means. Then repositioning by changing posture and supporting mobility to relax tense muscles and reduce stress. Then hot and cold treatment like hot water bottle and placing a cold cloth on the forehead, that also helps. मैडम एटा भी होतिला एबे कोन प्रॉब्लम चलेतिला based on this madam has already explained the research part, so concluding based on this finding combined with existing knowledge about the effect of contraction on placental circulation and fetal oxygenation, it is reasonable to conclude that prolonged exposure to frequent uterine contraction plays a role in pathogenesis of hypoxic ischemic encephalopathy. So this hypoxic ischemic encephalopathy is caused by lack of oxygen to the brain before and shortly after birth. So it affects the central nervous system. So baby born with HIE may have neurological and developmental problems. So what is the ideal time for cord clamping? Do we know it? So what is the ideal timing?
फिजियोलॉजिकल
So before when we were trainees, we used to know that 1 to 3 minutes or till the cessation of pulsation, whichever is earlier. But in midwifery practice we say that we have to wait for weight. ओजन करिया पे हमको रहिया को पड़िबो or till the cord becomes white. And also there are evidences in the recent researches that now there is no need to clamp the cord until the placenta is delivered. So there is beautiful video. Actually sir has shown that. So I don't know if the sound will support or not. So there are different organization was recommended different timings for delayed cord clamping and cord milking. So this cord milking is no more there and it has has been absoluted, so we don't recommend cord milking nowadays. Now umbilical cord clamping, so another research, it has shown that clamping of umbilical cord immediately increases the systemic peripheral resistance, resulting in an increase in arterial pressure, that is after load. So Deuce and Ridolph in 1977, they have told that. So however, as the placental circulation receives 30 to 50% of fetal cardiac output, cord clamping transiently reduces venous return by 30 to 50%, which combined with the increase in afterload decreases cardiac output. So this umbilical cord clamping, that is not recommended early, it should not be there. So it is delayed cord clamping. So in another research, it has been, is delayed cord clamping until placenta delivery beneficial? So the studies have been done, and oxygen saturation and heart rate transition during initial 5 minutes and delivery in Indian healthy newborn, it has been shown. And there is 170 newborns were taken in delayed cord clamping group and 178 newborns in early cord clamping. So it has been observed that in delayed cord clamping group, newborn had a higher SpO2, that is 3 to 80% compared to early cord clamping group. So group newborns. So delayed cord clamping group newborn has also slower rise in heart rate compared to early cord clamping group during the first 2 minutes, facilitating smoother cardiopulmonary transition. So there has been many randomized control trial of oxytocin at the beginning versus end of the third stage of labor for prevention of postpartum hemorrhage. So this study had been done in Boston, USA. So it concluded that postpartum hemorrhage were less frequent when oxytocin administration was delayed until after placenta delivery. So there were many researches which have been done. So this in 2018, so in a randomized control trial, the effect of timing of oxytocin administration on postpartum hemorrhage incidence was evaluated in women with low risk for postpartum hemorrhage in Turkey. So it concluded in level 3 care hospital, timing of intramuscular oxytocin administration did not influence the incidence of postpartum hemorrhage in women with low risk of postpartum hemorrhage. Hence, administering oxytocin after delivery of placenta is as safe as before delivering the placenta. So, in another study also, it was concluded that the administration of prophylactic intramuscular oxytocin after placenta expulsion in vaginal delivery has the same efficacy and safety as when it is used before placental delivery, and it is considered an easier alternative, especially if there is only single birth attended. So now we are very much aware of the microbiome. We are talking nowadays, we are talking about skin to skin contact, so golden hour. So one golden hour, the baby should not be separated from the mother, rather after birth the baby has to be put on the mother's chest and skin to skin contact, one golden hour, no weight, no vitamin K, nothing, and the initiation of breastfeeding has to be there. So this microbiome, as we are all aware that we have trillions of bacteria. So these are, so just I will like to say that baby pick up microbiomes in different ways. So by type of birth, cesarean and vaginal birth. So skin to skin contact, the location of birth and the ways babies are fed. So intervention that are detrimental to the microbe, that is stomach was and gastric lavage and antibiotic use. So this protects the, so I will not go into details. So there is a striking difference in bacteria for babies born vaginally compared with babies born cesarean section. So babies born by cesarean section are often colonized by bacteria from skins of caregivers such as nurses, doctors, midwife, anesthetic and anyone else who is present at the time of birth. One expert doctor on microbiome has stated that babies born by cesarean section could have functional equivalent of a birth defect. So this is the ideal setup of MLCU with birthing, all birthing equipments and the birthing stool. So this neonatal resuscitation trolley which ma'am was talking about, So this enables physiological cord clamping and resuscitation with intact placental circulation. So I will request our HOD and nodal officer ma'am to kindly procure if this is available somewhere. So ma'am was also talking about improving oral hygiene during pregnancy improves the outcome of pregnancy. So periodontitis is associated with preterm birth and low birth weight, and high level of carcinogenic bacteria in mother can lead to increased dental caries in infant. So oral hygiene is very much important. So there is another research which illustrates, do you understand the intrauterine environment? So how the intrauterine environment is there, so in which the baby is there for 9 months, and how the baby is adapting when it is out, when the baby is out in the extrauterine environment. So in these pictures we can see different reactions of the baby. So it will give us more of impulse that the baby is, there is also many videos that girls sanskar and other things. So mother physiology, mother emotional, mother socially, how mother is socially and how mother is culturally. So it has different impact on the intrauterine environment. So influence of mode of delivery, that intrauterine and extrauterine environment, nutrition and disease, and their linkage on shaping cognition of India or the future of India, that is in terms of the birth. So these are 2 videos. I don't know it will work or not, no idea. On positive pressure ventilation.
Show the other one. Here actually the coach.
So there is another slide which is saying that researchers told that cutting the cord before all of the baby has been born is like cutting the oxygen cord of an astronaut. If the baby has shoulder dystocia and his oxygen cord has been cut, this baby could become very sick and die. So wait until both the baby and placenta have been born and cord is wide before clamping and cutting the cord. And if there are knots in the cord, that is long umbilical cord or true knots, so these knots do not affect fetal heart rate or increase neonatal morbidity. So this is the new skin to skin contact with no clamping or cutting of the cord. Mother gave birth in squatting and is now lying on the cushion and a mat on the floor.
Placenta in the kidney tray. Here देखो ऐसे ये आम केमी डेलीवरी कर जो काढ़ी बेबी के माँ पेट को थी दौचु से जमा से एक्चुअली तक स्लो डेलीवरी हो जमा टणा टणी ना बेबी आम ये टाणी पकाऊ तो टाणी
Hands off amorosity
देख देख किसी नहीं देख हमें तो देखती बड़ा कौन ऑपरेट करूँ टाणी आनी पेट को थी दो तब लुक फॉर द सेकंड बेबी किसी करी से पर तेरे कंप्रेस हो चुका है
तो मैडम से कांदी बनी छुआर जदि ऑडियो थांता है लाउ ट्राई वाज ऑडिबल बेबी द कांदी चलते
खराब साथी आसे रोई था रे
हां या कैपिटा छ हो कांदन कारी करके देखिए रो देख कोन हो किछि कोड क्लैंप हो इतनी प्लास्टिक भी बाहर तार सांगे वाली ट्राइबल मान के एमती डेलीवरी हुए ये कहीं लिथोटो में डेलीवरी हो तो एक्चुअली मैंने बोधे रिकॉर्डिंग पाई करछन ये वर्ष को सुने जो पसंद कले कि सुन हो ना मैं दे प्रेफर करना कर दिया ये प्राइस ऑपरेट ଏମିତି ଆର୍ଟିକୁଲର ପଳେଇବ କଣ? ଗ୍ରାଭିଟିରେ ପଳେଇବ?
ଗୋଟେ କ୍ଲୋଜ ସିଷ୍ଟମରେ ଗ୍ରାଭିଟି କଣ କାମ କରିବ?
ପ୍ଲାସେଣ୍ଟା ବି ସେମିତି ଆସିବ
ତ ପ୍ଲାସେଣ୍ଟା ଡେଲିଭରି ହବ ନ କଟା ହେଇକି ଏଗୁଡ଼ା ପିଜିଏସନ୍ ଥିସିସ୍ ଦିଅ
मैक्सिमम प्रेशर तो एई टाइम रे ना
ଏଇଟା ପ୍ଲାସେଣ୍ଟା ବାହାରିଲା
ऊपर से बोलते प्रेशर देला
नहीं मसाज
वेट से ऊपर प्रेशर देला
मसाज
अच्छा मैक्सिमम यूट्राइन प्रेशर थर्ड स्टेज
छुआ तो
नहीं
छुआ के तापर प्रेशर
वाला रिकवरी कर
मैडम ये गुजरात रे वीडियो ना
गुजरात में
मैडम जो अछंती से फ्लावर साइटिंग अवार्ड
गुजरात ना जोधपुर
ना गुजरात
but this was not so
this video is from
गुजरात मेडिकल
मैडम आपण जो जाईतले देखिथिबे से लेडी जो छिड़ाई छी
साइड रे जो छिड़ाई
साइड रे पटरे जो छिड़ाई छी
आने मैडम वो इंडिया सारा बुले हम नहीं देखले देखिबा कुआडे कुआडे से मैं सब गुजरात लेडी मैडम सही लेडी को देखती
Now lastly, kangaroo mother care to reduce morbidity and mortality in low birth weight infant. So kangaroo mother it reduces morbidity, mortality. Aw kichhi nahi sori gala madam. Amra preconception, antenatal, intrapartum, postnatal. Thank you.
very good
Leo